Hello, my name is Michael Neff, and I am a second year athletic training Master's in Science grad student, and I am doing my poster presentation on understanding the recognition, treatment, and overall prognosis of a Stener lesion. So while doing my clinical rotation in the fall of 2020, working with Division I collegiate football, I worked with a 22-year-old male football player who was playing at the safety position. His overall timeline of this specific pathology, he first reported pain in his right thumb on October 27th, 2019. Eventually he got x-rays, which showed a Stener lesion, which I will get into, on November 5th. And then on December 9th is when he had surgical implementation conducted. And the patient still receives rehabilitation up to this day. So when it comes to the evaluation and diagnosis of a Stener lesion, we have to know a little bit about it. First, the overall pathology. So the common name, which is Stener lesion, is a progressed pathology from gamekeeper's thumb, also known as the medical terminology, which is an avulsion fracture of the first metacarpophalangeal joint due to displacement of the UCL, or the ulnar collateral ligament of the thumb. Upon inspection, a clinician may see and notice localized pain and excessive swelling in the adductor compartment and thenar eminence. And then also in medical terms, they might see ecchymosis surrounding this area. When evaluating for this injury, a valgus stress test is seen as the gold standard for ruling in this pathology. Differential diagnosis for this specific injury may include a volar plate injury, de Quervain vein disease, an RCL ligament injury or a radial collateral ligament injury, flexor pollicis longus tendon rupture, and a metacarpal fracture. There's a lot of anatomy involved when it comes to this injury of a Stener lesion. So the MCP joint is a diarthrodial joint, which mainly means that it's involved with flexion and extension with limited abduction and adduction. The static stabilizers that are associated are the volar plate, the dorsal capsule, and the UCL and RCL ligaments. When it comes to dynamic stabilizers, these are the muscles that surround the area. So we have our extrinsic muscles, which are comprised of the extensor pollicis longus, extensor pollicis brevis, and flexor pollicis longus. And we have our intrinsic muscles, also known specifically as the abductor pollicis brevis, flexor pollicis brevis, and the adductor pollicis. Etiology, or the onset for this injury, is usually hyperextension and hyperabduction of the first MCP joint, as you may see in the top picture. As you can see with the pictures below as well, those are x-rays of this specific patient that I worked with, and you can see the avulsion fracture just distal to the first metacarpal portion of his thumb. When it comes to the prognosis of this injury, research shows that 90% of patients with a complete rupture of the UCL treated with primary repair within 3 weeks have been reported to have good to excellent outcomes regardless of repair method. However, delayed presentation and/or treatment often results in extensive surgery with poor overall result. When it comes to the plan of care for a Stener lesion, We, of course, want to have surgical intervention, as I just stated, within 3 weeks of injury to have good to excellent outcomes. Modalities that can help with the overall healing process and aid in that include a paraffin bath and slush bucket, which may also lead into range of motion activities. And while also using these modalities, our range of motion activities can consist of thumb ABCs and static stretching of the wrist into flexion and extension. When it comes to cardio, of course, we can do your typical cardio on a treadmill, elliptical, or simply running on the track. But since this is an upper extremity injury, the UBE, or upper body ergometer, would be preferred. For strengthening exercises, we can use many dynamic exercises such as rice bucket, finger webs, putty, and then more typical strengthening exercises with the use of bands and free weights, such as resisted supination and pronation, resisted wrist flexion and extension, and farmers or suitcase carries. Lastly, when it comes to progressing to sport-specific drills, we want to make sure that the athlete has adequate proprioception retraining, such as single leg toss and catch progression. And something that I liked to use during this specific exercise was using a ball that was squishier and squishier upon progression, and then also using a Bosu ball to work on that balance and proprioception. Something that I found interesting about this patient in particular was it was almost a year post-operative that I started to work with him, and he was still receiving rehabilitation to this day in 2020 after receiving, or late 2020 after receiving surgery in late 2019. My theory for this is because it took almost 5 to 6 weeks to receive surgery after first reporting the injury. As stated in the research, with the overall prognosis of this injury, outcomes may be diminished when not treated within 3 weeks of rupture of the UCL.